Alright, step number 6, check the Q wave. If the Q wave is more than 2 small boxes deep, it is said to be a pathological Q wave. Pathological Q waves are a sign of previous myocardial infarction. They are the result of absence of electrical activity. A myocardial infarction can produce scar tissue and is electrically dead and therefore results in pathological Q waves. Pathological Q waves are not an early sign of myocardial infarction, but generally, it takes several hours to days to develop. Once pathological Q waves have developed, they rarely go away. However, if the myocardial infarction is reperfused early, the stunned myocardial tissue can recover and pathological Q waves disappear. The pathological Q waves needs to be present in at least 2 contiguous leads to be considered abnormal. Lead 2 and lead 3, for example, not lead 2 and AVF. The exception is the lateral leads V6, 1, and AVL, where the Q wave duration only needs to be 30 milliseconds to be deemed abnormal. Alright, this is an example of normal Q waves and pathological Q waves. This is an old inferior MI showing Q waves in leads 2, 3, and AVF. Step number 7, check the QRS complex. This term can be confusing as not all of ECG leads contains all 3 of these waves, yet a QRS complex is said to be present regardless. For example, the normal QRS complex in lead V1 does not contain a Q wave, only a R wave and S wave. But the combination of the R wave and S wave is still referred to as the QRS complex for this lead. The normal duration or interval of the QRS complex is between 0.08 and 0.10 seconds. That is 80 and 100 milliseconds, or equivalent to 2 to 2.5 small boxes. When the duration is between 0.10 and 0.12 seconds, it is slightly prolonged. But if QRS duration is greater than 0.12 seconds, it is considered abnormal. The QRS duration will lengthen when electrical activity takes a long time to travel throughout the ventricular myocardium. The normal conduction system in the ventricles is the His-Purkinje system and consists of cells that can conduct electricity quite rapidly. In normal electrical conduction, the SN node fires, AV nodes receive the impulses and then to the ventricles via the His-Purkinje system. This is a fast and result in a normal QRS duration. When electrical activity does not conduct through the His-Purkinje system, but instead travels from myocyte to myocyte, a longer time is necessary, and the QRS duration is widened. A widened QRS duration occurs in the setting of a right bundle branch block. So this ECG here is the typical example of right bundle branch block. And this one here is left bundle branch block. Wide QRS duration can also be seen in non-specific intraventricular conduction delay and during ventricular arrhythmias, such as ventricular tachycardia. This is an example of ventricular tachycardia. Okay, step number 8. Check the QT interval. The normal QT interval is controversial and multiple normal duration have been reported. In general, the normal QT interval is below 0.4 to 0.44 seconds, or equivalent to 5 to 10 small boxes. Women have a longer QT interval than men. Lower heart rate also results in a longer QT interval. Due to the effect of heart rate, the corrected QT interval is frequently used. The corrected QT interval is considered prolonged if greater than 0.45 seconds in males and 0.47 in females. It is calculated using Besset's formula. You need to obtain the duration between 2R waves and your QT interval. QT interval divided by the square root of the RR duration. I will leave you to practice that formula. You know, as a nurse, the most important is we must at least able to distinguish abnormalities in our patient's ECG. In real scenario, if you are ward nurses handling 4 to 6 patients, or in a fast track in an accident emergency unit, you have no time calculating some ECG components because you have a lot of care to prioritize. However, if you are equipped with the prerequisite skills to read ECG and able to identify abnormalities, you can refer it immediately to the specialist for definitive diagnosis and to interpret the subtleties, right? Okay, there is a quick way to distinguish a prolonged QT interval. This is to examine if the T wave ends beyond the halfway point between the RR interval. If the T wave ends past the halfway point of the RR interval, it is prolonged. So that is the easy way to quickly determine if there is a prolonged QT interval. Okay, prolongation of QT interval can result from multiple medications, electrolytes abnormalities such as hypocalcemia, hypomagnesemia, and hypokalemia, and certain disease states including intracranial hemorrhage. This is an example of normal QT interval, and this one here is prolonged QT interval. Okay, step number 9 is to assess the ST segment. The ST segment normally remains isoelectrical or has a slight upward concavity. ST segment depression or ST segment elevation can indicate cardiac pathology. Flat, downsloping, or depressed ST segment may indicate coronary ischemia. So this is an example of ST segment depression. ST depression may be associated with subendocardial myocardial infarction, hypokalemia, or digitalis toxicity, whereas ST elevation may indicate transmural myocardial infarction. So in this example, this is an acute inferior myocardial infarction, and there is ST segment elevation in lead 2, 3, and AVF. So, in diagnosing myocardial infarction, ECG is essential because one of the most significant findings of MI is the presence of the ST segment elevation. A 12-lead ECG can be used to determine which coronary artery is most likely affected by an ischemic event. For example, in this ECG, the ST segment elevation can be seen in leads 2, 3, and AVF. Recalling that these 3 leads view the inferior wall of the heart, you can assume that the right coronary artery is where the infarction located. Okay, step number 10, finally, is to check the T wave. The T wave is positive deflection after each QRS complex. It represents ventricular repolarization. The characteristic of normal T wave, it is upright in all leads except AVR and V1. The amplitude is less than 5 mm in limb leads and less than 10 mm in precordial leads, 10 mm in men, and 8 mm in women. The T wave abnormalities are peak T waves, hyperacute T waves, inverted T waves, biphasic T waves, camel hump T waves, and flattened T waves. On this sample, the T waves is tall, narrow, so these symmetrical T waves are characteristically seen in hyperkalemia. Then, this one is broad asymmetrical peak or hyperacute T waves are seen in the early stages of ST elevation MI and often precede the appearance of the ST elevation and Q waves. They are also seen with the prismal angina. Okay, how about inverted T waves? Inverted T waves is normal finding in children and can be seen in myocardial ischemia and infarction, bundle branch block, ventricular hypertrophy, pulmonary embolism, hypertrophic cardiomyopathy, and high intracranial pressure. T-wave inversion in lead 3 is a normal variant. However, if there is a new T-waves inversion compared to the previous ECG of a patient, this is always abnormal. Pathological T-wave inversion is usually symmetrical and deep greater than 3 mm. Okay, this is an example of left bundle branch block. It produces T-wave inversion in the lateral leads 1, AVL, and V5 to V6. And this one here is the right bundle branch block. It produces T-wave inversion in the right precordial leads V1 to V3. Okay, how about biphasic T-waves? There are two main causes of biphasic T-waves: myocardial ischemia and hypokalemia. The two waves which go in opposite direction. So biphasic T-waves, due to ischemia, the T-waves go up then down. And as you can see here in the example, there is two T-waves which go up and down. So how about hypokalemia? The T-waves due to hypokalemia, instead of up and down, the T-waves go down then up. How about camel hump T-wave? If the T-waves has a double peak, this is a camel hump T-wave. There are two causes for camel hump T-waves. Number one is prominent U waves fused to the end of the T-wave as seen in severe hypokalemia. And then hidden P waves embedded in the T-wave as seen in sinus tachycardia and various type of heart block. So this is an example of a prominent U waves due to severe hypokalemia. And as you can see, there is two peak T wave. And then this one here is hidden P waves in sinus tachycardia. You see there. And then this hidden P waves is marked first degree heart block. And then this one are hidden P waves in second degree heart block with 2:1 ratio conduction. Okay, the last one is platent T waves. Platent T waves are non-specific finding but may be represent ischemia if dynamic or in contiguous leads, or electrolytes abnormalities like hypokalemia if generalized. So this one is dynamic T wave flattening due to anterior ischemia. The T waves return to the normal once ischemia is resolved, usually. So this is an example, a dynamic T wave due to anterior ischemia. And this one here is generalized T wave flattening, which is found in hypokalemia, associated with prominent U wave in the anterior leads V2 and V3. Alright nurses, that's the end of the tutorials. I tried my best to make it short, but it can be. It has to be this long in order to tackle the most important points for you to be equipped with the knowledge on how to read ECG. Thank you guys. Please share this video.